Education Committee IFS from 2018 to 2022, Secretary General of Indian Fertility Society from 2016 to 2018, and Chairman of Infertility Committee AOGD from 2016 and 2018. Sir had many presentations, and from 2006, Sir had 20 international presentations in ASRM conferences, also 19 international presentations in national meetings since 2017. So with this, may I request Sir to kindly inaugurate our Shield Connect platform. So, sir, can you please click on that link? It is our digital platform, and this platform is basically for doctors, for the patients, and for the caregivers as well.
Thank you, Dr. Parachi. I think
On the link, sir. Yes, it is opening.
okay.
So this is a one-stop destination for the data dissemination of the scientific data dissemination and also for the educational activities. There are many pages. Thank you, sir. Thank you for the inauguration, and thank you, Chitra.
My pleasure.
Thank you, sir. So we'll begin our webinar, and we have an eminent speaker, Dr. Kuldeep Jain. Sir is Director and IVF Specialist of KJ IVF and Laparoscopic Surgery Center in Delhi. Also Program Director of KJ IVF Center in Faridabad. Founder, Secretary and past President, Indian Fertility Society. Chairperson of International Exchange Committee, Indian Fertility Society. Editor-in-Chief, Fertility Science and Research. Chairperson of Infertility Committee, AOGD. Member of Education Committee, International Federation of Fertility Society. Member of Endoscopy Committee of AOGD. Also advisor is Delhi Gynecologist Forum and executive member of AOGD. So with this, may I request and invite Sir for his talk on clinical dilemmas in endometriosis. Over to you, sir. Thank you.
Thank you, Dr. Prachi. It is my pleasure to be connecting through this platform to all attendees from Chennai and around. I'm really happy to be speaking on a subject which is very close to my heart. Dr. KD is there as a chairperson, and it is again indeed an honor that I am speaking on this platform. I will be speaking on a subject that is endometriosis, that is always in controversies, dilemmas, and debate. Before I start my talk, I take this opportunity to sincerely appeal to vote in my favor, as I am contesting for Vice President Foxy North Zone this time, and I seek your blessings and support. Voting is starting from 1st September to 10th September. So please log in on the Foxy website and please vote for me. I have been serving Foxy for last 35 years and worked in various roles. My last assignment with Foxy was the Endometriosis Committee Chairperson, which was very fruitful and productive. And that gave me impetus to work more and more for Foxy. So now I am presenting myself in a bigger role as Vice President. So I request all of you to support my candidature and vote for me from 1st September to 10th September. This is my workplace where I've been practicing for almost 20 years now. My topic today is clinical dilemmas in endometriosis. This is a very apt quote as far as the endometriosis is concerned by Sir William Osler. He who knows endometriosis knows gynecology, and that is very, very true. These are some of the facts which one must consider when we are discussing endometriosis. It is a disease of controversies and complexities. Uh, Starting from the etiopathogenesis, diagnosis, management, and follow-up, there are a lot of dilemmas, how it is happening, how you should go about. I will be going in detail regarding few of the clinical dilemmas. It is a chronic and multifactorial disease, progressive. It is always progressive till the lady ceases menstruation. It continues to grow, and that's why the recurrent is very, very common. It is not a malignancy, but behaves like one. So whatever you do, whether you treat it medically or surgically, it comes back and troubles you. And of course, very difficult to diagnose and treat. Now, what are the aim when you are having endometriosis in your patient? We need to control the symptom, whether it is infertility or pain. You have to prevent the recurrence. Whatever you do, medical or surgical, the recurrence rates are there, and you have to choose a strategy which can reduce the recurrence or prevent the recurrence. Improvement of fertility is very, very important. So that we have to keep in mind when the patient is having infertility as a presenting symptom, and we need to reduce the number of surgical intervention. Usually the presentation in reproductive age group is either as infertility or pain. I will be taking infertility first. And these are some of the burning questions when you talk of infertility. What are the options available? Is there any role of medical treatment? Does endometrioma affects ART outcome? Should endometrioma be removed before IVF? If yes, then how? What is the current practice? What are the principles of lap surgery? What are the factors which affect decision making, whether you should go for lap surgery or for IVF or for that matter IUI? So coming on to the options, there are 4 options available for endometriosis. One is medical, surgical, ART, and we can combine all these 3. As far as the infertility is concerned, medical option is a great no. There is not much role of medical management as far as the infertility is concerned. This is a Cochrane database on medical management, and they have clearly concluded that there is no evidence of benefit for subfertility by medical management. So, and moreover, it delays conception. So, as far as the medical management is concerned, in fertility, very limited role. We will discuss where is the medical management comes into infertility. Now, coming on to the surgery, how it can help these patients. Certainly, because there is a tubo-ovarian relationship which is disturbed, so we can restore the anatomy. That is very, very important. We can do the adgylysis, and tubo-ovarian anatomy can be restored, and that is helpful in the management. Ovulation is not interfered. Whenever we are giving medical management, ovulation is interfered, and that's why it delays the fertility. So if after surgery, the patient can go in first cycle, next cycle for fertility management. And after surgery, because you are doing bulk reduction, there is a change in the internal milieu which favors pregnancy. And of course, there is a larger disease-free interval. And laparoscopy remains the best tool basically for diagnosis, treatment, and follow-up evaluation of endometriosis. So what are the options when we talk of surgically? These are multiple options like transvaginal ultrasonography guided aspiration, which is again is not a very good option, and it should be avoided because it doesn't treat the disease, it doesn't suppress the disease, and there are very high chances of infection when you enter into the endometrioma. So this is not a treatment which we should offer. Again, the laparoscopic aspiration is also not a treatment of choice. So people usually what they do, they aspirate and come out, and that is not recommended. So what is left when we are planning surgery? Either you have to excise the lesion or you have to fulgurate the lesions. And then you can do the total cystectomy in a case of endometrioma. You can combine all these techniques depending on the type of the endometriosis, grade of the endometriosis, and of course we need to do a lot of adhesiolysis and nodule resection. Excision can be done. As an infertility consultant, what are the concerns when we are doing surgery that we need to remember? Ovarian reserve and AMH is one thing which we are always worried. And whenever we are putting a knife in endometriosis case, this is the most important concern which we have to keep in mind, because there are a lot of data suggestive of that after surgery, whatever you are doing, however careful you are, however experienced you are going to affect ovarian reserve and AMH. So this is one concern which we have to keep in mind. Second concern is always the recurrence. So choose a technique which can reduce the recurrence. That is very, very important. And third is minimizing complication. One has to minimize complication because the important structures like bowel and bladder are usually adherent in these cases. So if you are not very careful, you can cause more complication, more harm than good. What are the principles of surgery? So you can reduce the recurrence, you can reduce the complication rate. You have to have a good surgical technique, meticulous hemostasis. Operating in right plane is very, very important if you want to conserve the ovary. So if you are not very careful in operating in right plane, you are going to do more harm. Gentle tissue handling, again, very, very important, especially when you are dealing with the tube, bladder and bowel. And of course minimal use of cautery, which is recommended in these cases, because again the chances of complications are higher if you are using a lot of cautery. This is a small video clip of endometriosis in various form you can get, like here it is surface endometriosis. You can see all types of lesions. There are white lesions, there are red lesions, there are black lesions posteriorly. So this is surface endometriosis, and here you can easily treat these patients. Most of the time the tubo-ovarian relationship in this stage is usually maintained. Maybe some adhesions in the ovarian fossa you may get, and that you have to release before you close the patient. So a meticulous survey is required, and ovary should be lifted from its fossa, because this is the place where the endometriosis start in beginning, and the formation of endometrioma starts from there. So you have to lift just by the blunt dissection. Usually we combine blunt dissection and sharp dissection, like here when the bowel is coming very near to the endometrioma, you have to do sharp dissection. This is the epiploiky of the bowel, and that was adherent here. And now you can see it is lifted by this blunt dissection, and you can see the surface endometriosis over the ovary. There is again in the pouch of Douglas, you can see on the other side there are the deposits. So it is very difficult to excise all these deposits. So what we do, we need to fulgurate them with bipolar, and whatever lesion you are seeing, they need to be fulgurated properly. So that leads to the destruction of the active tissue, active endometrium, and that increases the chances of conception post surgery. After doing fulguration, you have to just do thorough lavage before you come out. Then that will you can leave some fluid in the peritoneal cavity to avoid adhesions, and that is all you have to do in these patients. And you can increase the fecundity. This is surface endometriosis of ovary, and here also there are the some endometriosis seen. So everywhere, wherever you are seeing the endometriosis, you can fulgurate, and that gives you a quite good fecundity with ART. This is another video of little severe grade. Here you can see the small endometrioma is also there, and both ovaries are just adherent to the pouch. Posterior surface is again very severe endometriosis is here, and there to find out the plane, we can use hydrodissection. I use a lot of hydrodissection to separate the tissue, and of course the blunt dissection here, and you can see the other side ovary and tube is also adherent. So on both sides, you need to do the dissection and lift the ovary. In these patients, usually the tube is patent. So if you have done a very good thorough clearance and tubo-ovarian relationship is maintained, then you can get a reliable and respective pregnancy rate after surgery when you combine it with IUI. But if the disease is more severe, then it is better to go for ART, because the fecundity rate in severe disease are not very good. Here you can see the posterior surface is again adherent, pouch of Douglas is adherent, the ureterosacral is adherent, and once the POD is cleared, you can fulgurate all the lesions as we have done before, and do a thorough lavage and come out. Usually the tubes are patent, but you need to test. If there is any hydrosalpinx, you have to treat that. This is a small endometrioma. You can remove it or you can fulgurate. Removal of endometrioma, actually small endometrioma like this, 1 centimeter, they are very difficult to remove. So you can always fulgurate because they are very small. But we always prefer cystectomy over fulguration. Fulguration and cystectomy, they have been debate whether you should fulgurate or excise the cyst. As far as the fecundity rates are concerned, both are same. Whether you are doing fulguration or cystectomy, chances of conception are good. But recurrence rate are quite high when you are not doing cystectomy. So that's why cystectomy is much more preferred than fulguration. This is another very severe case, grade 4 endometriosis, where you can see bilateral endometrioma on both sides, and whole pouch. These are kissing ovaries, whole pouch is adherent, bowel is adherent, tube is adherent. So these are very difficult case to operate, and one should be very expert, because first surgery is always should be a great surgery. You can see bowel is adherent, so we have to use sharp dissection. You should not use blunt dissection when the bowel is adherent to your cyst. And here you can again see near the tube fimbria, you have to use the sharp dissection. So and these are the patients where if you are doing cystectomy, you are losing a lot of tissue, because this is bilateral endometrioma. So you have to find a right plane. I usually use a lot of vasopressin to avoid excessive bleeding. And after the cystectomy, you need to fulgurate all points which are bleeding or endometriosis which is seen. This is on other side. Again, on this side, you can see a better plane than the other side, and you can go on doing the cystectomy. So after cystectomy, though you have done the very good job, cleared the pouch of Douglas, done both sides cystectomy, these are the patients which should go for IVF even after doing this surgery. So they get a better chance of conception. You can see the cystectomy being carried out, and at the end you have to fulgurate all deposits. This is the cyst wall. So you have to remain at the 90-degree angle to give a better traction. So that is very important. And when you are doing a large cystectomy, many a times there are a lot of bleeding. So you should not persist on doing the cystectomy. If you are having a lot of bleeding, especially near hilum, you can combine the cystectomy with fulguration, and that is one good technique to avoid excessive ovarian reserve damage. So at the end, you can see finally the POD is cleared, everything is cleared. When you compare the result of surgery alone and combine, you can see here this is a paper from Donage, and a very old paper, I think 2006. Endoscopy alone, only 23% is the fecundity. When you combine it with ART, you can double it. So it is always advisable. There should not be any conservative uh, period, conservative therapy after surgery. One should directly go either for IUI or IVF to get a optimal result. And that is the recommendation of SRA also, 2017. You can see grade 1, grade 2. After surgery, one can go for 3 or 4 cycles of IUI, and you get a quite improved pregnancy rate. But when grade 3 and grade 4 is there, though tube are patent, but relations are not maintained, and these are the patients which should go for IVF ICSI. Now coming on to this debate, this is very great debate whether you should go for laparoscopy before IVF. There are not many randomized trials are available, but most of the studies suggest that surgery does not benefit patient undergoing IVF. So even if you are having endometrioma, you should not touch it, and you can go ahead for surgery. That is what most of the studies recommend, and that is the recommendation in our practice also. Though there are many points which are put in favor of surgery before IVF, but these are all can be avoided. Basically, if you are avoiding puncturing, you can avoid risk of pelvic abscess. Rupture of endometriosis is not very common. Retrieval difficulties hardly any if you are having experience. So these are more of the theoretical points which goes in favor of surgery. This is some of the literature which says that there is no effect on outcome whether you go for surgery or not. There is no effect. There is no effect on response to stimulation, so you get a better harvest even without surgery. But in some cases where you are going for surgery, you can have reduced number of oocytes and reduced pregnancy rate. So that's why surgery is not recommended in these cases. This is again a paper in 2009 recommended IVF directly to avoid complication related to surgery. So there is enough data to suggest that surgery should be avoided when you are going for IVF. Uh, what is the impact of surgery? Why it should not be done? Cystectomy is always associated with decreased ovarian response to controlled ovarian hyperstimulation. That is one observation. And there is no effect on reproductive outcome. That is very, very important. So whether you are doing surgery or not, the effect on reproductive outcome is not much. And when you see the level of AMH and ovarian reserve, there's this paper 2012, significantly reduction of serum AMH level after surgery. And again in this patient, basal AMH level was significantly reduced after surgery. And this is a very good paper. Here you can see when you are doing a cystectomy in endometrioma, you are removing normal tissue almost double. Here this is non-endometriotic cyst, 32% normal tissue is removed. Here 65%. Whether you are doing laparoscopy or laparotomy, so this is very, very important paper which suggests that you are removing the normal tissue along with the uh, Graafian follicles. So how do you make the decision? That is very important for all clinicians. Age of patient is very, very important. If you are having a young patient, recently married, having a good AMH, you can plan surgery. That is a primary option. But if the AMH is low, older patient, and the prolonged infertility, you should directly go for IVF. Certainty of diagnosis, if you are not very sure that it is endometriosis, you have to go for surgery and send it for histopathology. Patient symptom, the patient is having severe pain along with infertility, you may consider surgery to relieve pain. That is the SRA guideline, that if the primary symptom is pain, you can go for surgery after explaining the patient that after surgery the chances of conception chances of decreased reserve will be more. Size of endometrioma again comes always in the discussion. Now it is 5 centimeter, up to 5 centimeter, you need not to operate. More than 5 centimeter, you have to individualize. Ovarian reserve again has to be taken into consideration. If it is low, you should not touch the ovary. Whatever is available, you should retrieve and then go for surgery, even if the patient is having pain. And of course, bilaterality. These are some of the recommendations from ASHRAE, which I have already highlighted. So I will skip these slides. When the patient is presenting as for pain and fertility is not the issue, then you are having medical or surgical management. If medical, what is best, how long and when to decide for surgery. We are having multiple drugs available for endometriosis associated pain. We can prescribe COCs. Then there are the oral progesterone available, which can be used as first line option. Dynogest is most effective oral option which is available, and the compliance is very good with Dynogest. So Dynogest could be a better option when you are comparing COC and progesterone. But as far as the efficacy is concerned, all are same, and anything whether COC, progesterone or Dynogest can be used. Dynogest is having now a lot of experience, and we are having safety studies also with Dynogest, so that can be a primary option. Then we are having GnRH analog. If the patient is not responding to your COCs or Dynogest, one can always use GnRH analog for 3 to 6 months. Only problem with the GnRH analog, they are very effective. Hypoestrogenic symptoms, so you have to give ADVAC if you are using it for a longer period. And then bone loss is also there, so that you have to keep in mind. Then we are having depot MPA, implants are there, and LNGs, which are very, very good, very effective in recurrent endometriosis, and in those patients who are having breakthrough bleeding. As far as the cysts are concerned, if the cyst is more bigger one, then usually the recurrence rate are very high with medical treatment, and you have to resort on to the surgery. Otherwise, if smaller cyst, usually they are very, very responsive to your medical treatment. But about the post-medical management, post-operative medical management, to reduce the recurrence, you can use 6 months of Dynogest or GnRH analog after therapy, and that reduces the recurrence rate, and it can increase the disease-free interval. In recurrent endometriosis, again, you can use Dynogest, GnRH analog or LNGs, all are effective, and you have to choose the therapy accordingly, according to the compliance, according to the age, and according to the severity of the disease. So finally, summing up, you have to make a balance, and that is very, very difficult when you are dealing with a situation where you have to preserve the uterus, preserve the ovaries, and at the same time you have to preserve the fertility. And that's why the management in endometrioma is really, really a tough task. Presence of endometrioma per se negatively influence ovarian function, and that's why the chances of conception are less in endometriosis. There is no definitive data which shows that effect of endometrioma is there on IVF ICSI outcome. So you can continue your IVF treatment along with the endometrioma. Large randomized trials are required to substantiate the benefit of laparoscopic surgery prior to IVF. For now, you have to individualize and treat accordingly, but most of the time we prefer not to go for laparoscopic surgery before IVF, and you have to individualize your approach considering the age, previous surgery, ovarian reserve, size, and bilaterality of endometrioma. So thank you very much for your patient hearing. I hope I have tried to solve a lot of questions here, and if there are any questions, I will be happy to answer. Over to KD.
Thank you, Kuldeep. It was excellent narration about endometriosis. Before you leave, let me ask you a very simple.
Yeah.
For infertility investigation, And
Can you repeat? Can you repeat your question, because my connection was lost? I couldn't hear you.
young couple married for 2 years, coming
Yeah.
for infertility investigation, and you find a endometrioma 6 centimeter.
Yeah, young patient, endometrioma 6 centimeter, because once you find a endometrioma, it is already a grade 3 disease. Okay. So when you are dealing with grade 3 disease, young patient, as I have suggested, you go for a ovarian reserve assessment, and primary treatment in this case is a surgical option that will always give you a scope to provide to correct the tube-ovarian relationship, to assess the nature of the disease, and grade it properly. And bulk reduction after surgery will help you in a better management. So in this patient, usually the primary management should be surgery before going to IUI or IVF.
You would like to remove it before.
Yes, yes. Cystectomy should be done. 6 centimeter, young patient, 2 years marriage, because she is having, if she is having a good ovarian reserve, you can provide her surgical management and then go ahead for IUI or IVF, depending on the tube-ovarian relationship. See, these are the patient. These are the patient which benefit most with your surgery, because it is a primary surgery. You can do a better job and reduce the recurrence. Can give a good fecundity rate if you have done very good surgery by IUI. Otherwise, you have to go for IVF if it is a grade 4 endometriosis.
Now you have removed this cyst, and she still continues with infertility and come back after 1 year with a
No, you should not leave. You should not leave these patients for 1 year. That is what I will like to highlight. They should always be in follow-up. You should not give any conservative management, because it is a progressive disease. If you are leaving her for 1 year for natural conception, that is not the right way of treating these patients. Just after surgery, if you go in the next cycle for IUI for 3 to 4 cycles, and if the patient doesn't conceive, I think she is a candidate for IVF.
Yeah, if patient disappear and come back after 1 year with a repeat recurrent endometrioma, then what will you do?
Recurrent endometrioma, I said, patient was having 6 months, the 6 centimeter recurrent endometriosis. Patient should go for IVF straight away.
Thank you. Because these are the things most of the gynecologists are facing in their day-to-day life.
Yes,
And
yes.
before
So,
Dr. Let me remind the audience that he is contesting for Vice President of Foxy. He is a dear friend of us. He is the president, past president, and founder secretary of IFS, and he was the chairman of the Endometriosis Committee. So we all look forward for all of you to support him for the Vice President Foxy. Thank you.
Thank you, Katie. Thank you very much, PM.
Kuldeep,
Yeah.
it was a nice talk, and
Thank
it was good, and wish you all the best. And
Thank
for
you so
the
much.
sake of the audience, I would like to say his better half is from Pondicherry, from Jipmer, Dr. Bharti Jain, and she is one of us.
Thank you. Thank you, Dr. PM. I'm sorry I have to leave because I had to join another meeting in Mumbai. So I am really sorry for leaving the meeting in between. I would have loved to be in connection with all of you. So thank you so much. And thank you, Shield Health, for providing us this platform. Thank you.
Thank you, sir. Thank you for that excellent talk. And it's a really pleasure and honor to have you.
Thanks.
Thank you, sir. Our next talk is on clinical applications of sperm function test, and it is my honor to invite Dr. PM Gopinath sir. Sir is Director and Senior Consultant, Institute of Obs and Gynecology and IVF, SRM Institute of Medical Sciences, Chennai, President-elect Fertility Preservation Society of India, Chairman of Board of Studies from 2016 to 2019 of Dr. MGR Medical University, and also Founder Secretary IFS Tamil Nadu Chapter. Sir had a specialty training in fertility preservation from Israel. He is a former professor of Madras Medical College and also a past president of FOXY. Sir is a recipient of many awards, including Leading Lights in ART Award in IFS Annual Conference in 2018 and also awarded Icon of the Year in IVF in year 2019. So with this, Nayar requests to deliver his talk on clinical applications of sperm function test. Thank you, sir. Yes, we can see your slides.
Um, Thank you very much for inviting me. I thank Sheil, and then my special thanks to my co-faculties and dear audience. And today we'll be talking on the special sperm function test. What are they, and what are the implications? Do we have to do it? Because in male infertility, if you take it, we have very simple semen analysis, which more or less gives us a lot of information when done properly, when read properly. So beyond that, there are a lot of other things which we have to see. What are they? There are some advanced testing of sperm function. That is the Antisperm antibody, which was very, very popular about 2 decades ago. And slowly in the era of ART, it is waning down. And sperm vitality, hypoosmolar swelling test, hyaluron binding assay, HBA, sperm chromatin assay. This is for DNA damage testing. And then we have some genetic testings like Y chromosome microdeletion and then CFTR gene testing. We will see the importance of all of them. If you take the immunological history, the infertility here, they are associated with about 10 to 13% of unexplained infertility. The antibodies may inhibit the sperm mobility and sperm zona and then sperm oocyte binding. So they may even affect the embryo cleavage and development. IgG and IgA are predominant. IgA most always occurs with IgG, and IgM are very, very rare here. So in the male, infertility following vasectomy reversal with normal semen count and motility, you might encounter this phenomenon. Unexplained decreased motility and immotile but viable sperm, agglutination or clumping, excessive clumping of the sperms, and then the spermatozoa, and testicular trauma, and then torsion, and repeated genital tract infection, what we call it as a male accessory gland infection. And in both the partners, it could be seen in unexplained infertility. So what are the antisperm antibody tests there? They are practically outdated, no longer used. Something like immobilization test, isogema test, and agglutination test like Franklin Duke's Hibrix test, and then a tray agglutination test. All of them have become obsolete now. Even the mixed antiglobulin reaction test, what commonly we know as MAR test. This is a mixed agglutination of red blood cells and sperm by second antibody, and it cannot distinguish the region of the antibody binding, where head or a tail or a neck, that it cannot differentiate it. The other test, the sperm MAR test, here the screening test using washed or unwashed sperms. Positive result should be confirmed with Immunobead testing. So the Immunobead testing is simple, sensitive, and specific. Commercially available microscopic polycrane, the spheres coated with anti-human immunoglobulin IgG, IgA, and IgM. They are all color-coded immunospheres there. The direct test on the sperm is the MAR test, and then sperm MAR and Immunobead test. It can be performed as a part of the routine semen analysis, particularly in cases of unexplained infertility. Indirect test by Immunobead only. This is from serum, cervical mucus, and also from follicular fluid, we can do it there. MAR test, the methodology, it is a very simple test. Mix a drop of semen on a glass slide with sensitized sheep RBCs coated with IgG. Add the antiserum to human IgG. So when you incubate for some time and then observe the slide for formation of aggregates of the sperms and the blood cells, Then the IgG antibodies are present. The sperm will have the red cells attached and a large aggregate will form there. The test is limited by the inconvenience associated with obtaining the human IgG sensitized sheet erythrocytes there. The test is replaced by sperm mark test and Immunobead. What is sperm mark test? Here, it is a mixed semen with the IgG coated latex bead instead of the sheep's RBCs. Here, they're using a latex beads and IgG antiserum on the slides. So, mix the semen and the IgA coated beads on a separate slide. Observe after 10 minutes. Determine the percentage of the sperm bound to the beads is called the agglutination. Not always able to detect the location of the bead binding because the degree of agglutination, if it is very severe, you won't be able to locate the test. The Immunobead binding test, here mix a drop of the semen and a drop of coated beads, IgG, IgA and IgM. Apply a cover slip, incubate for about 10 minutes, observe using the phase contrast microscope. Determine the percentage of motile sperms with attached beads. Determine the location of the attached beads, whether it is a head or a midpiece or tail. So this methodology, it is an indirect test here where you incubate with negative washed sperms with heat inactivated test serum or fluid with a washed sperm. Perform the test, direct test on this particular sperm. So this is practically you'll be duplicating. When you see that, you will see that they will be agglutinating with the RBCs as it is shown in the slide here. How do we interpret this? Need to have a positive and a negative control sera. For MAR and sperm MAR, positive, that means 50% or more sperms have adherent particles or RBCs. Suspected positive is between 10 and 50% adherent particles. Then the Immunobead test, IBT, 20% of the bead binding positively test shows there is a clinical positive there. But when it is more than 50%, it correlates with an abnormal sperm parameters. So it is probably the less than 20, it has got no significance there. Region of bead binding, it can be a head, midpiece, or even a tail. The types of immunoglobulin, IgG, the most commonly, especially after vasectomy. IgA is more detrimental. IgM are very rare, may point to other autoimmune disorders if you detect it there. So the antisperm antibody testing, how do we clinically signify is? It rules out immunological infertility, must consider complete history of the male and female partner when determining the possibility of immunological infertility, and interpret results of antisperm antibody testing with caution. The presence of antisperm antibody is not predictive of male infertility. If you see a positive antisperm antibody, you cannot say that they will not conceive. That's a very, very important point which we have to consider. Treatment of immunological infertility is same as standard treatment paradigm of unexplained infertility. Ultimately, it will include even assisted reproduction technologies like IUI, IVF, and ICSI. The sperm vitality is tested. Often we come across situations where the identification of the live sperm with intact cell membrane. You will see sheets and sheets of sperm, but they are not moving. We have to find out whether they are dead or immotile there. So what do? We use a dye exclusion test or hypoosmolar swelling test. And highly recommended in cases where progressive motility is less than 40%. It is clinically important to know if the motile sperms are alive or dead. Presence of a large proportion of live but immotile sperm may indicate tail structural defects. High percentage of a dead and immotile sperm may indicate the epididymal pathology. So this is the important thing, why we have to see that. And dye exclusion, the basic concept is the damaged plasma membrane allow entry of certain strains. So using and nigrosin staining, using is the vitality staining, and then nigrosin the counter staining, allowing a easy visualization of the cells. The dark pink stained cells have taken up the eucin and are considered dead, whereas unstained sperm with white heads are considered live. The lower reference limit for the live sperm, as per the WHO, will be about 58%. The next test probably is the hypoosmolar swelling test, where the ability of the sperm to maintain an osmotic gradient across the cell membrane, where live sperm will swell in a hypoosmotic buffer. Used as it is diagnostic test in cases of low motility, which much the same as that of the dye exclusion vitality test. Select the viable sperms in a specimen with only non-motile sperm to be used for ICSI. So normal is about at least 60% should be swelling. Results of the routine HOS test do not change the patient's management. Negative test does not predict male infertility. So this is how you will see that the sperm tail will be coiled and curved. So this is to show that it is positive. At least about 30 minutes, you just have to do that. Another test is sperm hyaluron binding assay, what we call it as an HBA. Ability of the mature normal sperm with intact acrosome to bind into the hyaluronic acid, the main mucopolysaccharide of the cumulus. The hyaluronic acid does not bind to immature sperm. So if you put them in a petri dish with hyaluronic acid, which has been coated, what we call it today, we have it as a pixie dish, you will see that the mature good sperms will go and bind to it. From there, when you take it, you will be able to do a ICSI. The commercially available kits or approved tests are available. It is a rapid, simple test associated with strict morphology and progressive motility, chromosomal aberrations, and fertilization in vitro. It may be used by laboratories as an adjunct to standard semen analysis as such in an ART cases. So this is how you will see it's how it is binding with the hyaluron there. So the clinical significance of this is the results correlate with fertilization in vitro, progressive motility, and normal morphology. But however, you cannot distinguish between the low fertilization rate and the high fertilization rate. Whether you will be able to say whether it's going to be a fertilizing potential, which we can just draw the conclusion here. Threshold not established to predict the sperm fertilizing ability. So the HPA can be used to determine between the standard insemination and then ICSI. It is not predictive of fertilization or fertility. There are some beyond the routine tests. There are two specific tests which is done today in a major proportions. One is sperm DNA integrity testing. Second is Y chromosome microdeletion. Other one is the CFTR gene testing there. Let us see what is sperm DNA integrity testing. The normal sperm chromatin essential for parental genetic transmission, whether it is present or absent or it is depleted. You will see there is it is like a strands of the DNA. A lot of steps will be there. Some of them might get detached from one side. Some of them will get detached from both the sides. Some of them will be free hanging. All of them are the abnormalities. So the DNA damage can cause infertility, recurrent pregnancy loss, poor outcomes in an IUI or IVF there. Here the principle is the quantification of the sperm DNA strand breaks. How much is a strand breaks seen? Where do you do the test? It is done with semen. Techniques, there are nuclear dyes, acridine orange dye. With that, then sperm cervix SCSA, and then their direct assessment DNA strands by using a tunnel and comet assay. Nuclear matrix axis is used as a halosperm. Some of them are available for the kits are available for us to do. For an SCSA, you need a flow cytometry. The equipment is given by Donovan, who was the inventor of the SCSA, and in fact, he has got a couple of units even in here in Tamil Nadu. He has got one unit in Coimbatore where he is doing it as an andro center. The DNA integrity testing is a marker of sperm function. So it can be an unexplained infertility with normal semen analysis, and it can be in a recurrent pregnancy lots, but these are all the candidates for IUI and IVF. The concept is like this, very simple. If you see there is a small amount of damage in the DNA, when it goes and gets fertilized, the oocyte has got an ability to repair and then make it all right and then go through a normal process of conception and embryo formation. If it is beyond the level where the oocyte cannot repair it, that's why when we measure, when we have a high DNA fragmentation, they cannot be fertilized yet. So we have to treat it before we take the patient. So where do you see this DNA integrity? It is elevated in testicular temperatures, for example, long distance drivers, and then furnace workers, inflammation, cigarette smoking, following a chemotherapeutic agent, especially alkylating agents, diet, drug use, air pollution, and advanced age. So these are all the cases where we get the DNA integrity there. Assessment of the DNA damage of infertility, more damage can come from the sperm from a fertile. See, for example, they have seen the samples from fertile men and they have seen the sample from infertile men. So the sample, the semen of infertile men contains more DNA damage than the sperm from a fertile man. It does not mean that fertile men will not have any DNA damage. They do have, but it will be a relatively smaller portion. Threshold of the DNA damage, fragmentation, abnormal chromatin packing, and protein deficiency, all of them impairs the development of the embryo, and then subsequent live pregnancy chances are reduced. Sperm DNA damage is associated with male infertility, but even fertile men possess detectable levels of DNA damage, which we should understand. Average, we probably will say around 10% is okay. More than 20% is abnormal, where corrective measures has to be taken. The dye that binds with the histone and the aniline blue or a nucleic acid acridine orange dye, where they use a flow cytometry with the SCSA or a SDFA. So these are all the various methods with which we do. And the results among all the tests has to be compared. There is no one test is superior, but the time-tested standard test is SCSA. The no conscious as to most accurate test of DNA damage, no conscious to threshold of the value to predict the reproductive outcome. There is a wide variability in the threshold values among the assays. Relatively expensive tests, because for example, if you take an SCSA testing, it might come to around 7,000 rupees. Requires specialized equipments like flow cytometry, fluorescent microscopy. But the important thing is it can be performed on a frozen semen, which allows testing to be done as a reference andrology lab. You can just freeze it and just put it in a dry shipping and send it to the lab where they can just do the test and get you back the thing. The clinical significance of this testing is high percentage of DNA fragmentation, natural or IUI consumption, where there is a reduced pregnancy rate and increased miscarriage rate. In an ART, if you have a high percentage of DNA fragmentation, there is an impairment in IVF and ICSI failures, impairment in the embryo development to blastocyst stage, there is an early embryonic arrest, and increased chances of chemical pregnancy and spontaneous miscarriage, decreased term pregnancy rates there. So the other reports also shows no association with pregnancy outcome. Further studies of sperm DNA damage is needed, but it is not recommended as a routine test. Consider in certain cases counseling for use of ART or donor sperm. In a flow cytometry, when you see that DNA fluorescence green can be qualified with the flow cytometer, which can be seen here just like in the picture. But however, you cannot do it on a severe oligospermia. There has to be the sperms available for them to count it. At least about some 3 or 5 million should be there present for them to just do the test. This is the equipment with which they just do the test there. So what about this clinical application? The DNA integrity testing and ART. If you take the pregnancy by DNA integrity test results in an IUI. When it is less than 30, you will see that percentage is about 20. When the DFI is more than 30, it comes down to less than 2.5. So this is the importance which you will do. Again, on this side, you will see sperm DNA integrity testing and IVF and ICSI. When it is more than 30%, IVF gives only about some 22%, whereas if you do a ICSI on them, it will give you around 40%. So that shows if there is a high DFI, better to go directly to the ICSI rather than trying on an IVF with that. Now, the next component is Y chromosome microdeletion. What is the background? The deletions are the cause of spermatogenic failures. Where do you test it? Men with non-obstructive azoospermia. The principle, we do a PCR analysis of the long arm of the Y chromosome. Specimen, it is only from the peripheral blood. Clinical significance, to predict the chances of finding a sperm or sperm retrieval techniques there. If you take the genetic of male infertility, you will see 80% it will be Klinefelter, and then about Y chromosome microdeletion will be only about say around 10%, and then predominantly congenital absence of VAS will be seen in about 5%. So this is the normal pictorial graph. So this is the Y chromosome, a long arm. When you just see that, you will see there are 3 zones there: AZFA, AZFB, and AZFC. If A is deleted, if you don't find it in the Y chromosome microdeletion analysis, it shows there is a germ cell aplasia and you cannot retrieve any sperm. So when you take a sperm for a non-obstructive azoospermia for a sperm retrieval, you do the Y chromosome microdeletion. If AFZA is deleted, you just go for only a donor insemination. Don't waste your time and patient's money. Again, AFZB is deleted. It shows it is a maturation arrest and there is no retrievable sperm. So when you have both A and B deleted, you just ignore and then go for the other options there. Whereas when C is deleted, it could be because of the hypospermatogenesis, and 70% chances of retrieving this testicular sperms for ICSI is there. So this is why this test has formed as a base test on all non-obstructive azoospermia before they are going for a testicular sperm extraction techniques there. To conclude, several sperm function tests have been suggested to be useful as a diagnostic tool in male infertility. This sperm function tests all have inherent weaknesses. None of them have been shown to be superior to the others in evaluation of the male infertility or predictability of pregnancy by a natural means or assisted conception, particularly ICSI. So in short, I would like to conclude saying that they have a very special role prior to the ART, but they cannot predict the possibility of the pregnancy. Thank you very much for your patient listening.
Thank you, sir. Thank you very much for that excellent presentation. Sir, it's my sincere request that we will take additional questions at the end of Man's talk.
Fine, Prachi.
As you mentioned, most of us are not ordering or doing this test in our routine practice.
Yeah.
But sperm DNA fragmentation is something which is coming up. And
we routinely do it.
Yeah.
We routinely do it.
So that is the one test people are doing routinely. And about the percentage of DFI in any given sample, if it is more than say 20%, this is the latest cutoff which has come in literature. Initially it was 30%, came down to 25%. Now they say even if the sample has more than 20% DFI, you have to discuss with the patient what you can do. And in
if you find out the cause, for example, if there is a varicocele, or if there's a male accessory gland infection, or if any other source of infection, we try to treat it. You give an antioxidants and then improve the measures and then repeat it to see whether you can just bring it down, and then thereby your results will be better.
I was coming to that, the role of antioxidant in such a patient. How long you will like to give?
Ideally, it has to be effective at least for about 60 days. So less than 60 days, it does not show any improvements. So minimum 60 days, you have to try the antioxidants, and then it's worthwhile doing it. So for cases where you are doing it, definitely taking it for ICSI on sperm retrieval techniques, 30 days is enough. If you are planning for an IUI and rather planning for a natural bouncing of the sperm back to normal, then minimum of 60 days has to be given.
Thank you. Thank you, sir.
Thank you, sir.
Dr. Gopinath, what is the role of varicocele in DNA fragmentation?
Yeah. So when you have a high fragmentation with a demonstrable varicocele, it's worthwhile doing a varicocelectomy, and it automatically improves the varicocele. If it is a subclinical varicocele with increase in DNA fragmentation, if you do a varicocelectomy, it does not improve.
How long do you wait after surgery to assess and
6 weeks.
6 weeks.
Thank you, sir. Thank you very much for that excellent talk, and I'm sure there would be many questions as well. Our next talk is on poor ovarian reserve, and it is my honor and privilege to invite Dr. Geeta Haripriya ma'am for the next talk. And ma'am needs no introduction. Ma'am is currently Medical Director of Prashant Fertility Research Center, also Fellow of Royal College of Obs and Gynecologist in September 2007. Ma'am is recipient of many awards, including Lifetime Achievement Award in 2010 by Gold Committee in collaboration with Harvard University in USA. Also received Best Doctor Award by Dr. NGR University, Blue Ring Award for the work in the field of fertility and diabetes, and Best Performing Doctor Award by the Government of Tamil Nadu for meritorious services in the field of medicine. So with this, may I request and invite ma'am for her talk on poor ovarian reserve. Thank you.
Good evening, everybody, and thanks for the lovely words of introduction. Now, the topic is diminished ovarian reserve. We all know that this is one of the major problems which we face in day-to-day practice. And most important of all, you'll be surprised at the number of younger women having a diminished ovarian reserve. So before, about 5-6 years earlier, or even 10 years earlier, it was only over the age of 35 that we were concerned with poor ovarian reserve. But today, we all know that we have a lot of patients less than 28 years who do present with diminished ovarian reserve. And in fact, antral follicle count and antral follicle count is routine, but anti-Mullerian hormone estimation as a routine testing, we never did earlier because of the cost implications. But today, looking at the large number of patients with the diminished ovarian reserve, it's become part of my routine practice to assess anti-Mullerian hormone values in all patients, even if they are less than the age of 28. So with this, let me start the introduction. Now, what is diminished ovarian reserve? It's a reduced capacity of the ovaries to produce oocytes, and the oocytes produced, very importantly, are of poorer quality, leading to formation of poor quality embryos, and most severe form of diminished ovarian reserve can be represented as premature ovarian failure. Now, the ESHRE consensus on the definition of poor ovarian response to ovarian stimulation for in vitro fertilization was the Bologna criteria, and it looked at 3 factors, and 2 of the following 3 features must be present to mark a person as having diminished ovarian reserve: advanced maternal age greater than 40, or any other risk factor for poor ovarian reserve like previous surgeries, and a previous poor ovarian reserve less than 3 oocytes with a conventional stimulation protocol, an abnormal ovarian reserve test, antral follicle count less than 5 to 7 follicles, or AMH less than 0.5 to 1.1. Now, looking at the physiology of poor ovarian reserve, Now, the presence of reduced number of FSH-sensitive follicles, a suboptimal exposure to gonadotrophins, that is like inadequate dosing for the body mass index. Also, it means that you've probably used a drug which was, which was destroyed or incapacitated by the poor supply chain, by the, by the supply chain, and the adequate temperatures were not maintained, therefore making it a low potency drug. Presence of FSH receptor subtypes rendering follicles less sensitive to exogenous gonadotrophins like the FSH polymorphisms. Now, when you look at age and fertility, according to CDC, this chart illustrates the percentage of married women who experience infertility by age group. So when do we seek help? Under 34, 1 year of trying to become pregnant without success. 35 to 38, you would start approaching for help at 6 months, and 39 and older after 3 months. And why is this so? Because by age 30, only 7% are infertile, 35, 11%, and age 40, 33% are infertile, and at 45, 87% of them are infertile. Now, what are the risk factors for a poor ovarian reserve? It could be, most importantly, it's advanced reproductive age, smoking, family history, and the Fragile X syndrome, a previous ovarian surgery, particularly endometriosis and ovarian cysts. This is a very, very important factor, and history of gonadotoxic therapy and conditions that can cause ovarian injury like radiotherapy and surgeries, and genetic conditions like 45X mosaicism. Now, what are the markers to predict? Age greater than 40, 4 to 6 months of oligomenorrhea, FSH greater than 25 international units at 2 occasions more than 4 weeks apart. Now, this is very, very important that you must do it at 4 weeks interval to tell you that it is an elevated FSH, AMH less than 0.35, a day 3 inhibin level of less than 45, testosterone levels less than 0.5 nanomoles per liter, and an antral follicle count of less than 5 or 6, and ovarian volume less than 3 centimeter cube. Now, the current Poseidon is very, very important to classify patients. Now, here we look at group 1, age less than 35, antral follicle count greater than 5, AMH greater than 1.2 nanogram per liter, with 2 subgroups, 1A less than 4 and subgroup 1B 4 to 9 follicles. Now, group 2, age is greater than 35, antral follicle count is greater than 5, and AMH is greater than 1.2 with 2 subgroups, 2A and B, with less than 4 and 4 to 9 follicles. Now, group 3 is the younger women, less than 35. Antral follicle count, however, is less than 5, and AMH is less than 1.2. These are all expected for ovarian reserve. And group 4, greater than 35, with less than 5 and less than 1.2, also expected for ovarian reserve. And what does it translate into? Group 1, the young suboptimal low oocyte number, and group 3, young expected low oocyte number. Now, the difference is in the age group. Now, group 1 and 3 are less than 35 years. So, though there are lesser number of embryos, still the aneuploidy risk is lesser. So, they are more effective and they are genetically competent embryos capable of producing an ongoing pregnancy. Whereas in group 2 and 4, they're old suboptimal low oocyte number, old expected low oocyte number. But here, because of the age group, there is a high embryo aneuploidy risk, and therefore the number of embryos actually going on to a live pregnancy is lesser. So overall, fewer embryos are generated in the diminished ovarian reserve patients, and there is a reduced cumulative live birth rate. Now, what are the ovarian reserve tests? Now, biologically, the chronological age is important. Biochemical test, static and dynamic, FSH, FSH-LH ratio, inhibin B, E2, and AMH. Dynamic tests, we hardly use them. And biophysical, ultrasound, antral follicle count, ovarian volume, and the Dopplers, ovarian blood flow. Histologically, ovarian biopsies, we don't use them anymore. Now, selection of protocols is highly individualized, and it's based on ovarian reserve. When there is an antral follicle count less than 7 or less than 5, AMH less than 1.1, the starting dose could probably be 225 to 300, and the protocols could be antagonist, agonist stop protocols, use of growth hormones, and natural cycle. In an average patient, 7 to 14 antral follicle count, 1.1 to 3.5 AMH, the starting dose could be 150 to 225, and you can use the long protocol or you can use the antagonist protocol. But the third category, the hyper-responders, antral follicle count is greater than 14, greater than 3.5 AMH. The starting dose should be low, 150, or maximum you can go up to 225. Here, you can use the antagonist protocol and the freeze-all strategy. Long protocol is very rarely used. We use it mainly in patients who have not done well with the antagonist protocol, and these are the patients who will be assigned to the long protocol, with very taking great care to make sure that they don't hyperstimulate. Now, how do you interpret your cycle day 3 hormone levels, which we do as a routine? When the FSH level is greater than 10 and estradiol is less than 70, the ovarian reserve is reduced. When it is FSH is greater than 10 and estradiol levels greater than 70, still it's reduced. And FSH level 2 to 10, but estradiol level greater than 70, still reduced. And what is ideal? An FSH level 2 to 10, estradiol level less than 70 when it is considered normal. Now, we did look at the AMH levels. The low AMH is 0.5 to 0.9, a normal range is 0.9 to 3.5, and high AMH levels is 3.5 to 9.5 nanograms per liter, like we see in those patients with polycystic ovaries. Now, the oocyte numbers are very important. And normally, we expect something like 15 oocytes, and that gives you a good pregnancy rate. You don't want a very low oocyte number because it doesn't give you good pregnancy rate. You don't want a very high oocyte number because they go in for hyperstimulation. And most of them, you would notice, you get lots of eggs, 35 oocytes, but then you get only 4 embryos or 5 embryos. So large numbers are not appreciated. Now, what are the problems in poor ovarian reserve? Poor and depleting follicular reserve. There's a mitochondrial dysfunction, there's reduced blood flow to the ovaries, and there is a high level of free radical damage. Now, a lot of drugs are available using clomiphene citrate, step up and extend it up to day 2 to day 10, clomiphene citrate plus FSH or HMG, and a step up protocol, low dose step up, and a low dose step up, step down protocols, and use of adjuvants, which we'll be seeing in the next few slides. Now, treatment strategies are very important. We use adjuvants to increase the reserve of the ovary. We use pre-treatment to synchronize the development of the follicles. We use proper stimulation protocols to get the adequate number of oocytes, and we use adjuvants later after the egg collection is done to help to improve the pregnancy rates and the live birth rates. Now, here we look at the pre-treatment protocols. The effect of estrogen priming, normally we do it in the luteal phase, but here it's found that it's beneficial to use it both in the luteal phase and to continue it into the follicular phase of the treatment cycle. So the cycle cancellation rates are lower, number of oocytes are higher, and number of embryos are higher when you use it both during the luteal phase as well as the follicular phase. In the luteal phase, in the luteal E2 treatment protocol, oral estradiol valerate 4 milligrams per day was initiated on luteal day 21 and either stopped at menstrual cycle day 3 or continued during the period of ovarian stimulation until the day of HCG injection, which is protocol B. And estrogen priming through luteal phase and stimulation phase improved ovarian responsiveness, and this may lead to an increase in pregnancy rate in poor responders with failed cycles. The ongoing pregnancy rate in group B was 27 versus 20% with group A. Now, how do you manage the group 1 and 2? Now, what are the reasons for the low response in these patients? Undertreatment, low probably due to a low BMI and therefore a low dose calculation. So it's very important to take the BMI into consideration and individualize your protocols. Now, genetic polymorphisms, we all know that the FSH receptor polymorphism is one of the current things which happen. So if you have a cycle where the patient has not done well, you did expect a good response, is not done well, it's well worth doing the FSH polymorphism to find out whether really there is a genetic factor associated. And the most important challenging problem is asynchronous development of follicles. So how do you synchronize the follicles to help you to get a good outcome? Now, luteal phase estrogen can be used, and you can use an antagonist protocol. Estradiol valerate, 4 milligram, that's 2 milligram twice a day from day 25, and you use it for 9 days. And you begin the FSH, either you get a period or you don't get a period, you still start after finishing the estradiol. The rationale is it decreases the risk of cycle cancellation, it increases the chances of pregnancy, and it improves the synchronization of the follicular pool. Sorry. Now, this is a quality management approach to controlled ovarian stimulation in ART, and that's called the Fisher protocol. And we start on day 20 of the previous cycle, give the norepinephrine 5 milligram for 10 days, stop, wait for a period, start the stimulation on day 3, and continue till the ultrasound shows you a follicle which is 14 millimeters. Then you start the antagonist and you move on till the time when the follicle size is 17, 18 millimeters, when you give your trigger and arrange for oocyte pickup. Now, the trigger can be an agonist trigger, and the oocyte pickup is normally done 36 hours later. Now, looking at the agonist versus the antagonist protocol, the agonist is the protocol of choice for normal responders, and there are lower cancellation rates, increased number of follicles, better pregnancy rates. But however, there were higher incidence of OHSS. So we thought it might induce excessive ovarian suppression in poor responders, and the short antagonist protocol was recommended to decrease the length and degree of suppression and increase the number of follicles. With agonists, however, there is better synchronization of follicles, and for poor responders, more is good. Even one oocyte is good. Higher number of oocytes and more number of embryos for vitrification gives you better pregnancy rates in these patients with a diminished ovarian reserve. So contrary to thinking that the agonist started in the previous cycle will actually bring down the reserve, bring down the number of follicles, we find that there is a better synchronization of follicles and better useful oocytes in the long agonist protocol. Now, administration of GnRH antagonist during the 3 days before initiation of the IVF cycle is another way to synchronize the follicles. The starting dose of FSH is 177 in the control group, and in the pre-treatment group was 166.9. Days of stimulation was almost same. Number of cumulus oocyte complexes was better in the pre-treatment group, 13.6 versus 9.9. And the ongoing pregnancy rate per started cycle was 33% versus 42.4 in the pre-treatment group with antagonist. So the number of cumulative oocyte complexes per oocyte retrieval was the endpoint in this study. And we've started using this and found it really, really useful in synchronizing the follicular growth. Now, what we should not do is to use the oral contraceptive pill for 1 month, which we normally do in our donor cycles, and we've been doing it in our regular routine cycles also, particularly in batch IVF. So we now know that most of the studies have shown that, and most of the meta-analysis have shown that the ongoing pregnancy rates, the duration of stimulation, gonadotrophin consumption, and number of oocytes were much lesser when we were much lesser when you stopped using the oral contraceptive pill. So using the oral contraceptive pill for long times is not recommended. And at the most, I use it for patients for only 10 days, day 16 to day 25, in those patients where the other protocols have failed, and it's very important to synchronize. So avoid oral contraceptive pill treatment, particularly when you're using the egg donors, because here you're anticipating an agonist trigger. So when you look at LH at the start of the stimulation, and there is always a suboptimal growth. So you must be worried with egg donors, and the tendency to give oral contraceptive pill and agonist trigger for all, you should not do it. Now, influence of the agonist and antagonist cycle in fresh IVF cycles. Now, when you compare the antagonist and the agonist cycles, the most important criteria which were taken care of is the stimulation number of days, which were almost similar. The dose of gonadotropin is almost similar. E2 on HCG day, slight higher with the agonist protocol, and the endometrium on HCG day is minimally higher with the agonist protocol. But the market changes where with the mean number of total oocytes recovered, which was 8.3 compared to the 5.31, and all these were statistically significant. The mean number of 2PN oocytes higher, 6.21 versus 3.71. Mean number of embryos available, 3.76 versus 2.54. The mean number of embryos transferred, marginal difference, 1.92 to 1.74. Clinical pregnancy rate, 57.95 compared to 32.06 with the antagonist protocols. And the ectopic pregnancy rate, 4.49. There's not much difference. The live birth rates, however, were different, 46.33 versus 24.96. And this is very, very important to note. Now, the data from the Mumbai clinic in 2019, 36 patients, first cycle antagonist and second cycle agonist, was searching for similar studies, but I could not find where studies where they have tried it in their own patients who had failed with the antagonist cycle and the second cycle using an agonist. So this has definitely shown a marked improvement with the agonist in the second cycle. The mean number of oocytes was 9 compared to 6.6. Grade 1 embryos were 30% compared to 17.5%. And the grade 1-2 embryos, 31.7 versus 17.5, almost a 50% increase. And grade 2-3 embryos were lesser, 65% versus 38%. So it shows that when you do an agonist protocol, definitely there is a marked increase. Most of us have been using antagonist protocols all these years, and this is an eye-opener, and we should be using agonist protocols. We've started using it in a big way, and it has given us great results. Now, how do you handle patients with lymphocyte groups 1 and 2? You increase the dose of FSH in the second cycle by around 50 to 75 international units, and this helps to improve the pregnancy rates in group 1 and 2 with normal ovarian reserve. And an increase in the FSH dose with previous suboptimal response may significantly increase the number of oocytes retrieved in the following cycle. So if you started with 150, you can make it 225, and that definitely gives you a better number of oocytes. And if you started with 225, you can maximum go up to 300, and you can get at least 12 oocytes. Now, in patients in group 3-4 with poor ovarian reserve, they're a different category. In these women, higher doses of gonadotrophins will not compensate for the absence of follicles. They don't have the eggs, they don't have the follicles. So what are we doing? Giving them higher and higher doses. So in patients with the reasons for the low ovarian reserve is age-related quantity and quality decline, other causes of low reserve like surgery or chemotherapy, genetic causes of low ovarian reserve, and unexplained. Now, stimulation challenges, that is the maximum gonadotrophin dose, is increasing gonadotrophin dose is going to help you. The cancellation rates in group 300, 450, 600 were the doses which were compared, and you find that the more you increase, the lesser the benefits, and the live birth rates is best in group A, 300, compared to group C and group B. So increasing the FSH dose in group 3 and group 4, current evidence does not provide a clear justification for adjusting the standard dose of 150 in poor or normal responders, as increased dose is generally associated with greater FSH consumption, greater cost, and no improvement in pregnancy rates. So we have to think of ways to get more oocytes by better techniques and in the same cycle, and the answer is the dual stimulation protocols. So dual stimulation seems to be the most promising approach to increase the number of oocytes collected in a single ovarian cycle. However, more embryological and clinical data are required, as well as analysis of its cost effectiveness. We've started using it, and we found that it really helps, and I think it's going to become the treatment of choice in the future. So what do we bank on? There are 2-3 follicular waves within a menstrual cycle. 68% have 2 waves and 32% have 3 waves. The early follicular phase wave is ovulatory. Existing antral follicles in the luteal phase can be stimulated. The study shows that double ovarian stimulations in the same menstrual cycle provide more opportunities for retrieving oocytes in poor responders, and this offers new hope for women with poor ovarian reserve and newly diagnosed cancer patients needing fertility preservations, where time is very, very important. You're only given that much of time to achieve the maximum number of oocytes retrieved. And even in our own patients, instead of doing one stimulation, taking a 2-month break and doing another stimulation, if you're able to achieve 2 stimulations within 35 days, it's definitely much, much better, and the time to pregnancy is much, much lower. So here we look at one of the protocols, and we started with the recombinant FSH and a recombinant LH. You can also use a HbHMG at 225 units, and when it's 14 millimeters, start the GnRH antagonist. Give the most important of all is that you should use only a GnRH agonist trigger, and oocyte pickup is scheduled 36 hours later, and then there is a 4-day break, and you start the same protocol once again. And the second cycle also, you give an agonist trigger, and collect all the oocytes, and you create embryos, you pool them and freeze them for future use. If there is a very low reserve, you can use chlorophene citrate 100 milligram from day 2 to day 6, or even for 10 days, and add on the your HPHMG to achieve the same results. Now, adjuvant therapies like growth hormone, is it indicated? Now, when we're pushed to the end and we can't find any enough number of oocytes, then we can use growth hormone. Like you look at this study, the odds are in favor of using growth hormone. You can use 4 international units a day starting day 3 till the day of the ovulation trigger, and it has improved the pregnancy rates and the oocyte retrieval rates. But the studies, some studies are good, some studies say no. But overall, if you look at the study, it favors the use of growth hormone. Now, pre-treatment with coenzyme Q improves ovarian response and embryo quality in reserve young women. The number of high-quality embryos was a primary outcome measure. There was a significantly lower gonadotrophin requirement, higher peak E2 levels, low cancellation rates, increased number of retrieved oocytes, higher FERT rate, 67.49%. More women from the treatment group had available cryopreserved embryos and more high-quality embryos. And usually a dose of 100 to 300 milligrams is used. And the higher number of euploid blastocysts with luteal phase stimulation and higher cumulative live birth rates with combined follicular phase and luteal phase stimulation. So this is a graph which shows you that the rate of patients obtaining at least one euploid blastocyst increased from 42.3 after follicular phase stimulation to 65.5 with the contribution of luteal phase stimulation. So the conventional antagonist ovarian stimulation does not take full advantage of the whole follicular cohort when you do only in the follicular phase, and adding on the luteal phase stimulation really helps to achieve more number of oocytes and better pregnancy rates. Now the next is LH supplementation. For whom and with what? The elderly women from day 1, hyporesponders definitely from day 6, 7, or from day 1 in subsequent cycles. And all patients with hypo, you start off using 300 international units of HMG. Poor responders, those with poor ovarian reserve, are controversial, and addition of recombinant LH does not increase the number of oocytes retrieved, the total dose of FSH cancellation rates, or the ongoing pregnancy rates. But however, there are other studies which say that there are significantly more oocytes, significantly higher clinical pregnancy rates with recombinant FSH plus recombinant LH versus recombinant FSH alone. There's a relative increase in pregnancy rates, 30% of poor responders. You can also use HPHMG, which is what we use, and definitely there is an increase in pregnancy rates. So HMG can be used alone or in combination with recombinant FSH to give you a good benefit. Now, looking at the HCG levels, increasing HCG levels are associated with more top quality embryos. And here you look at the HCG level on day 6. And as the HCG level increases, there is an increase in the number of top quality embryos. Patients with higher concentrations of HCG have significantly more top quality embryos. And when you look at the pregnancy rates, HCG on day 6, the higher it is, the better the pregnancy rates. And at least if you have, this is a study which you co-administer GnRH antagonist and HCG for final oocyte maturation, double trigger in patients with low proportion of mature oocytes. And regarding the HCG, if you give 200 international units of HCG from day 6 and continue till the ovulation trigger, the number of oocytes retrieved are better. Now, the comparison between IVF cycles with HCG versus double trigger. So now you're moving on to all these slides. You were dealing with the stimulation protocols. Now you're going on to the trigger. So rather than using HCG alone, if you use a double trigger, the agonist and the HCG, the number of oocytes retrieved, the number of M2 oocytes, and the number of M1 oocytes, the number of 2PN embryos, the number of M2 per number of oocytes retrieved, the number of top quality embryos, number of embryos transferred, and the ongoing clinical pregnancy rates were much, much better with the dual trigger. So what is the dual trigger that you're going to give you the best benefit? The type of triggers, HCG 6,500 only, and HCG 6,500 plus 0.2 triptyline. The clinical pregnancy, the FERT rate was 58.6 versus 73.1. Clinical pregnancy rate 20.7 versus 33%. Live birth rate 14.5 versus 26.9. miscarriage rate of 37 versus 17.4, and the cancellation rates were much higher in the control group, 15.4 versus 6.1. So dual triggering the final oocyte maturation with GnRH agonist and the standard dose of HCG can significantly improve live birth rate, clinical pregnancy rate, and fertilization rate in women with diminished ovarian reserve undergoing the GnRH antagonist IVF-XC cycles. And also in the GnRH antagonist IVF-XC cycle. So dual trigger seems to have come in a big way, and just like the dual stimulation protocols. Now, moving on to the adjuvant therapies. Now, use of transdermal testosterone, the T-Transport trial, transdermal gel for poor ovarian responders. It pre-equips preantral follicles with more FSH receptors, increases the cohort of follicles surviving to the recruitable antral stage and follicle stage, increases the oocyte yield and reproductive outcome in women with poor ovarian reserve. And the poor responders fulfilling Bologna criteria, 5.5 milligram testosterone by transdermal route, preferably 2 months prior to controlled ovarian stimulation, seems to be the preferred therapy. Now, the other adjuvant which we use is DHEA, and this study concludes that DHEA supplementation can increase the expression of the AR in pre-ovulatory follicles, both in vitro and vivo. The selective beneficial effects of DHEA supplementation on ovarian response in diminished ovarian reserve women may depend upon increasing expression of AR and FSHR in the germinal follicle. Improving the follicular reserve, how does DHEA supplementation help? FSH receptors are increased and expression is increased, ovarian response is increased, there is decreased atresia, increased follicles, useful follicles, increase in the reserve, increase in the oocyte quantity, and insulin-like growth factor 1 is increased. There's better quality of oocytes and better quality embryos. Now, the role of mitochondria in female reproduction, the production of energy for the metabolic requirements of the oocyte provided solely by the mitochondria, which is the energy factory in the cell in the oocyte. Oocyte has the largest number of mitochondria and mitochondrial DNA. During the recruitment of follicles, there is a marked increase in mitochondrial mass from 6,000 copies to 200,000. And here, the benefits of mTOR come in. When prescribed before ovarian stimulation in ovarian reserve, the antral follicle count is increased and the AMH levels are increased. The diminished ovarian reserve is associated with reduced mitochondrial DNA count, and this is where it helps. The mitochondrial DNA in normal women is greater than 3 lakh, and in diminished ovarian reserve women, it's less than 1 lakh. So with ovarian aging, role of mitochondria in oocytes, this is a present study in 2016. And the observation is that the change in ovarian response and embryo quality after 90 days of L-leucine, that is mTOR, 800 milligram capsules in poor ovarian response patients undergoing COH for IVF or ICSI. So pilot cohort study in a tertiary care fertility clinic and reproductive medicine institute. 30 subjects with POR and previous failed IVF cycles were enrolled, supplemented with 800 milligram of L-leucine once a day after meal. Subjects undergoing second cycle of controlled ovarian stimulation were also included. The mean antral follicle count before treatment was 6.9 and after 90 days it was 8.2. Average oocyte number before treatment was 4.53 and after treatment was 5.53. Total M2 oocytes increased by average of 1 oocyte after treatment. Average number of day 3 cleavage grade A embryos before treatment was 1.4 and after treatment 2.23. So the conclusion was the mean AMH level before treatment was 1.3 and after treatment was 1.8. Peak estradiol levels on day of trigger before treatment is 1308 and after treatment was 1473. Statistically significant increase in antral follicle count, oocytes retrieved, and number of grade A embryos, and there's an increasing trend in the mean AMH and peak estradiol levels. Increase in total grade A embryos improves embryo transfer and pregnancy rates in a poor responder. For a poor responder, 1 extra oocyte or embryo could increase the chance of pregnancy and avoid a donor program. So 800 milligram of leucine daily could offer hope to poor ovarian reserve patients, where improvement in ovarian response and embryo quality would offer better chances of pregnancy. This is a fairly recent introduction, and I think we need a lot more studies to actually bring it into routine practice. However, there is a ray of hope in using this drug, and I think till all studies make it a routine practice, we can continue using it and try, because even like it rightly said, even one extra oocyte is very important. And how do free radicals damage fertility? So there's an age-related quality decrease in the ovarian reserve, cellular malfunction caused by the accumulation of ROS, compromised antioxidant defense systems, and deteriorates oocyte quality by inducing apoptosis. So vitamin D3, the next in our armamentarium. So diminished ovarian reserve, it normalizes AMH levels, normalizes granulosa cell expression, and deficiency in pregnancy increases risk of gestational diabetes, recurrent pregnancy loss, preeclampsia, and small for gestational age babies. So what do we recommend currently? Coenzyme Q, resveratrol, which is one of the current drugs which have come in and which seems to be showing promise. ARG, we've been using it for years and it seems to show promise. Testosterone gel, 2 months to stimulation. The first choice for stimulation is the long agonist protocol with HB-HMG 300 international units. You can also use recombinant FSH and HB-HMG, but now the trend is moving slowly towards using HB-HMG. The second choice, because we all know that LH is important in the stimulation protocols and it's important for follicular genesis. So the transition is now moving towards HB-HMG. Now the second choice is estradiol or antagonist pretreatment, clomiphene citrate 100 milligrams, day 2 to day 10, recombinant FSH 150, HB-HMG 150 with antagonist and dual trigger. And dual stimulation is one of the current protocols, very, very successful, and might soon be the first choice in poor responders. And when you do 2 stimulations, you collect all the oocytes, make them into embryos, and you freeze the embryos from both stimulations and plan for a frozen embryo transfer later. Now, the next is the freeze-all policy. When do you freeze all? When the serum progesterone is less than 0.5 or greater than 1.5, and previous biochemical pregnancies or early pregnancy loss with fresh embryo transfers, previous ectopic pregnancies and IVF with fresh ETs, poor responders undergoing embryo accumulation, patients with endometriosis, and the need, because you want to treat the endometriosis, and particularly like in the previous talk by Dr. Kuldeep Jain, he said, you collect the oocytes, then you treat the endometriosis, particularly those with, with widespread endometriosis. You don't want to give the GnRH agonist before stimulation, but you can give it after stimulation, and in the gap, all the deposits will dry up, and you can use the following embryo for a frozen embryo transfer. But most important of all is in adenomyosis, where you can collect the oocytes, create the embryos, reduce the size of the uterus by using the GnRH agonist protocol. GnRH agonist for at least 3 months, and after that you can do your frozen embryo transfers to get the best outcome, because these are already patients with a diminished reserve. They have a low number of embryos, and you want to give them the best chance, that is the first chance. And therefore, you prepare the uterus adequately before you actually put in the embryos. You also freeze embryos when you need to do a PGT. And if you detect a polyp during the COS cycle, when the estradiol levels are very high, and patients with polycystic ovaries, definitely it is a yes for a freeze-all. And high responders with more than 20 follicles, you definitely give them a freeze-all policy. Those with documented ovarian hyperstimulation, those with a thin endometrium, you want to do a hysteroscopy before a frozen embryo transfer, identify the cause for a thin endometrium, treat it, try to improve, and then you do a frozen embryo transfer. And those with repeated IVF failures, you definitely want to do a freeze-all. Now, is assisted hatching useful to all? It's not useful to all, but women in the higher age group, it may be useful. There are controversies to say that it is useful, it is not useful, but when this patient is coming back many times, you can use it, particularly when you find that the zona is very thick. I think it helps. And definitely ICSI for all in the patients with diminished ovarian reserve, because you can't face a failed fertilization. And it's definitely better for the poor responders. When you want to give the best embryos, you have no reason for a failure earlier, then you want to do a PGT, particularly because she's in the older age group and she has had, in the earlier obstetric history, she has had some miscarriages. then it's better to do a PGT before you transfer these embryos. Now, the current is the latest in the scenario, PRP. So the live birth rates in poor responder group after previous treatment with autologous PRP and low dose ovarian stimulation compared with poor responders who used only low dose ovarian stimulation before IVF. The clinical pregnancy rate and the live birth rate were 33.3 and 40 in the PRP group and 10.7 and 14.9 in the control group respectively. More studies, however, needed in the future. Even though the treatment of poor ovarian responders remains a therapeutic challenge, the use of intra-ovarian injection of autologous PRP in patients with poor ovarian reserve before IVF brings a glimpse of new hope in increasing the success of IVF, defined by clinical pregnancy and low birth rate. Personally, we've been doing quite a lot of ovarian PRP, and we can't say it helps everybody, but definitely, at least in 25% of patients, there has been an improvement. And I was just listening to a talk by Dr. Naina Patel in the morning, and her pregnancy rates with the PRP were much, much higher. And I think the type of preparation is very important. And if you follow all the protocols in using the PRP, the minute you prepare and you freeze, thaw, and then you put it in immediately, then the pregnancy rates are much, much better. And doing a laparoscopic procedure and a vaginal procedure, I think laparoscopic procedure has a marginally better performance compared to the vaginal installation. But if you're going to do 2-3 times, then it's better that you do one laparoscopically followed by the others vaginally, and this gives a better pregnancy rate. Now, oocyte donation, the end of the scenario, when there's nothing else that you can offer, then you offer oocyte donation. And so treatment strategies, the adjuvants to improve ovarian reserve, appropriate retreatment protocols, suitable stimulation strategies. The dual stimulation and dual trigger have brought in a lot of hope. Laser-assisted hatching only in appropriate patients, PGT when necessary. We all have to remember that even one oocyte is all that is needed to have your own biological baby. And this is very, very important in putting in all your efforts to give them their own baby by trying all the current things in the scenario to give them their own baby. Thank you very much.
Thank you, ma'am. Thank you very much for that excellent talk. Very useful, and thanks a lot. We will have a question and answer session now. So, first question is already there. That question is there for Geeta ma'am, Dr. Geeta ma'am, that is for you. The question is by Dr. Lakshmi Srinivasan, and the question is, can you explain this dual stimulation protocol? Some additional information about dual stimulation protocol.
Yeah, the dual stimulation protocol, like I had shown earlier, on day 3, you start your HMG, HB-HMG, or a combination of recombinant FSH and LH, or recombinant FSH and the HMG, and you continue the stimulation till your the follicle is 14 millimeters when you give antagonist to bring down the LH values, and you continue till the follicle is 17 or 18 millimeters when you give your agonist trigger. The most important to remember is the agonist trigger. So when you give the agonist trigger, then 36 hours later, you plan your egg collection. After this, there is a 4-day break. And following this, you start the same stimulation protocol once again. You start with your recombinant FSH or your HB-HMG, continue till your follicle reaches 14 millimeters and start your antagonist. And once 3 lead follicles are around 17, you give your trigger, which should be an agonist trigger once again, and you plan your egg collections. So what I do is I don't freeze the first batch of oocytes. We do the ICSI and we freeze the embryos. Then we collect the eggs once again and create embryos and freeze it once again.
Thank you, ma'am. Thanks a lot. We are waiting for a few questions. Dr. Nayar, do you want to say something? Do you add flavor? Yes,
ask Dr. Geeta, ma'am.
Yes.
What's your experience of using double trigger, dual trigger in this poor responder?
Yes, I have. Yeah, we use quite a few. We use it, and particularly when you have these follicles, there is one follicle which is 17, 18. the others are all 14, 15, then we find that when we give the dual trigger, all these 14, 15s also grow, and you get, when you get only, what we normally expect is only the 17 to come up, all your 14s also come up, and then you get much more number of oocytes. So the dual trigger is very useful in these situations. But the other place where it is very useful is when you have more oocytes and all of them are not synchronous in their development. That also helps because it brings in all the smaller the follicles, and you get much better oocyte numbers.
Yeah, because generally this dual trigger was advocated in cases when you have the empty follicle syndrome and
Yes.
empty follicle. So you are more careful the next cycle. You don't want to take any chance.
Yeah. I think that's where the idea came from, to use it in the.
I just want to ask, what is your thinking? I don't know whether you have used it or not. Can we use this dual trigger in the second phase of dual stimulation, the luteal phase of stimulation, of dual stimulation? Can we use the dual trigger there when you're giving agonist the second time?
Yeah, I did use it for one patient. It was good. Though they, in the actual protocol, they recommend only the agonist. Now in the second phase, my follicles are all little asynchronous. So I used it and we found good results. Only one patient I have used.
Oh,
That is what we follow it up in the fertility preservations. From the luteal phase, we start up with the.
Yeah, I think that will be wonderful if we can do some more number cases to see what is the effect of dual trigger in a dual stimulation, the second part of the dual stimulation, when the number of follicles are less, maybe a little bit asynchronous. The dual trigger might be useful there also. But it's a very good idea. You see, you have given me a lot of stimulus to use dual trigger in many more cases than only for the empty follicle with the history of empty follicle previously. That is what we are doing till now. We are not using dual trigger in a routine way, but probably it will come up. And
Thank you, sir. Thank you very much. There is one more question from Dr. Jayashree. How to give luteinizing hormone in POR patients?
You mean only the recombinant LH? I don't use much of recombinant LH. I use HPHMG instead. I think it gives the same results. So when we want to use, when we want to combine recombinant FSH and LH, then I use HPHMG instead of using the recombinants. Or I use recombinant and I use HPHMG instead of the luteinizing hormone.
Right, ma'am. Ma'am, there are a lot of questions for you. Is there any need to give small dose stimulation on the day of trigger if there are few 15 mm follicles apart from the larger one?
I think they mean, do you want to give your stimulation on the morning and the trigger in the night? I think that's what they mean. Yeah, we have done it, but what I do is I slightly reduce the dose so that, because if you're going to give a dual trigger, that itself helps the smaller follicles to grow. So there are times when we have done that and it has given us good results. We don't do it as a routine, but when there's a big discrepancy, when you have 3 batches of follicles growing, one at 17, one at 15, and the other at 14, different batches, then you can give your normal stimulation in the morning, but at slightly lower dose is what I use, and you can give your double trigger in the night. So we do use it, and we've had no ruptures, no premature rupture of follicles.
Right, ma'am. Thank you, ma'am. Can I take one more question? The question is from Dr. Vidya. The question is, can we use letrozole or clomiphene for dual stimulation?
I have used only clomiphene, and most of the studies have shown only clomiphene. Some studies have, there is not a lot to recommend in letrozole. I'm not sure why, but most of the studies have used only clomiphene, and the Japanese also use more of clomiphene in their protocols than letrozole. I use letrozole more for developing the endometrium in an FET cycle when you're not able to do it with your routine, estrogens. But as a form of stimulation, though technically yes, because you can, when you use it in an IUI, you can use it in an IVF protocol. But most of the studies have used only clomiphene, and even the the Shanghai protocol has used only clomiphene. So at the moment, I've been using only clomiphene.
Right, ma'am. Thank you very much. I'm waiting for some more questions, but I don't see any additional questions now. So we can close this webinar. So thank you very much. Thank you, ma'am. Thank you, Nayar sir. Thank you, Gopinath sir. Thank you very much for.
Thank you. Thank you for a very good offer. It
Thank
was
you.
lovely. Thank you very much. I
Thank
enjoyed it.
you, Dr. Geeta, Dr. Gopinath. Thank you very much.
Thank you, sir.
Thank you, sir. Thank you very much.